We're back again for another episode on medical experts in football. I'm Taiwo Adeshubin, your host.
Be confident. Be confident in your diagnosis, be confident in your skills. That is probably trust your judgment. I think that's probably the thing that the advice that I would have liked someone to have told me when I first started working as a physio.
Here's Andrea Mosler, an Australian sports physical therapist and research fellow at LaTrobe University, and she completed her PhD on the risk factors for hip and groin pain in professional male footballers. Aside from her research and her clinical duties, she has worked 3 Olympics. We'll discuss Australia, her Aspetar experience working in Qatar, and of course, a lot of groin and hip rehabilitation considerations for all sports medicine professionals, but especially physical therapists. So, are you from South Australia?
That's a little bit of a loaded question. I was actually born in California, believe it or not.
Wow.
And my parents immigrated to Australia when I was 3. So I spent my whole life growing up in South Australia, in Adelaide. Mm-hmm. And then I moved over to Canberra, where I live now, where I worked at the Australian Institute of Sport for 18 years. And then I moved to Qatar to do my PhD looking at
Okay, well, we're going to get to that. Don't you worry. But what's your favorite childhood memory that you spent? Was it in Adele,
in Adelaide?
City? Adelaide. Oh, I said Adele. That's a singer.
Adelaide. Yes, yeah. Adelaide. Okay, so look, probably one of my most favourite memories of growing up in Adelaide was going to the beach. So Adelaide has very nice cruisy beaches. It's not a lot of waves. So as a child, it's really comfortable and it's very warm there. It can get very hot in summers. So going to the beach was something that I really loved. And then the other thing I really loved was going to my local Australian football team who had a home ground not very far away from my house. I could actually hear the crowd.
Oh, that's sweet.
So I grew up with actually Australian rules football, which is the most popular sport in South Australia.
Lacrosse and rugby, right? Both are pretty strong in Australia.
Yeah, lacrosse actually is pretty strong in South Australia for some reason. That must be a cultural reason. Rugby union is not really played very much in South Australia. It's played more in the eastern states, so particularly in the ACT, New South Wales and Queensland. Football, as in soccer, is popular throughout the country, particularly at junior levels. But Australian rules football is definitely the number one football code in the southern states. So in Victoria, South Australia, and also in Western Australia and Tasmania.
Gotcha. So you enjoyed rooting for your team, but did you play yourself?
Well, I did play with my brothers, but I'm quite old. So women actually weren't allowed to play Australian rules football after about the age of 5. So there was actually no leagues for us to play. So I was definitely born in the wrong era because I would have loved to play. So I do actually play now with my kids in a modified rules for old people, basically. But, it's fun. It's really fun.
Well, what sports were you able to play back in the days, in the 80s, right?
Yeah.
Was it 70s?
70s and 80s, yeah. So netball was my big sport. So I played that my whole life up until fairly recently, probably five or 6 years ago, I stopped playing. And netball is like it's an English version of basketball where we have a round ball and shoot through a hoop, but it's a non-contact version of basketball, basically.
That's real chill.
It's not so chill.
It's not chill,
but it's
you said it's non-contact though, so you can't even touch them.
Well, you sort of do, but it's officially non-contact, but there is a fair bit of contact, especially when I play.
Interesting. Well, from what I hear, because I had a previous Australian physical therapist talk about his experience getting into PT school. And in the States, it is quite hard to get into school. Tell me about your time when you were trying to apply to school. First, I guess, when did you realize physical therapy was the profession you definitely wanted to pursue? And how difficult was it for you to get in?
I remember distinctly the moment I decided I wanted to become a physio. That was when my mother went and saw a private practitioner, and she had a neck problem. And this physio was so dynamic and really seemed so engaged and loved her job. And I just thought it was amazing that you could help someone treat their pain, get their pain better, get them back to being physically active and give them exercises. And since I love sport so much, it just seemed like the perfect. I loved sport, I loved helping people, I loved working with people. And so for me, it just seemed the perfect job for me. So I decided at that age, which was around about 14, 15, that's what I wanted to do. And I have come from a fairly academic family, and so academic ability was not a limitation for me. So I just got straight in from year 12. Yeah.
Nice. And year 12 is
technically
like right after high school.
Yeah, that's the final year of high school.
Yeah. Okay.
Yeah, like the final year of secondary school for us. Yeah.
Okay. So you said sports has certainly been the thing. How did you shape your early career into a focus of working with athletes? And obviously we'll get to the Aspetar and all the other things you've been doing with the research, but early on, what did you do to kind of shape it in the way that you wanted to?
Yeah, that's a great question. So really, I enjoyed a lot of aspects of physio when I was at university. I really enjoyed working with kids. I enjoyed different aspects of rehabilitation, but really the thing that I enjoyed the most was the opportunity to work with sport. And it's because sport is just in my blood, it's in my family. It was my most enjoyable thing I did outside of work. So when I finished, I actually did a year of working in the biggest hospital in South Australia. And I am really grateful for that year that I had, because I worked across a lot of different areas of the hospital, and I think it gave me a very good general medical knowledge or knowledge of medical conditions, which then when I went into private practice, I felt gave me, it was a really good grounding, particularly for things like red flag type things. Yeah. And I picked up a few nasty conditions in those first couple of years as a very young, graduate, I think, helped by that first year. So basically after maybe a year in private practice, I'd already developed a relationship with a local swim coach who went on to, it turned out he had 3 athletes that became members of the Australian swim team and won Olympic medals. So it was it was just a bit of a coincidence, a happy coincidence that I made this connection with him as a swim coach. And he started bringing his athletes to see me. And I made the connection just because he owned the local swimming pool. And I wanted to start running hydrotherapy classes for my patients, because I really saw the benefits of exercise, way back before it was kind of the evidence was there. So that's really how it happened. So he just got me to work with his athletes, and then I started working with going to swimming camps and competitions. And actually even before that, even as a student, I had been doing trainer coverage for community men's football teams. So I'd already sort of had that experience of covering Australian rules football. And then I had the swimming relationship. And then my next workplace, I was working at a velodrome, actually. It was a sports injury clinic. So I moved into a big sports injury clinic in Adelaide. where I had a much higher percentage of patients who were athletes.
Yeah.
And I worked in a velodrome, so I saw higher level cyclists. And by that time, I had started my sports masters. So I started my master's degree in sports physiotherapy. I was the second graduate of that course in Adelaide. Okay. So I started that really 3.5 years after graduating in physio. So very early, I felt like it was needed to go into doing some postgraduate education. And then from there, I developed a relationship with the South Australian rowing coach. And again, they had junior international gold medalist rowers. And so I started working with rowing and then I moved over to the Institute of Sport. So that's sort of how my career.
And I think that's an important point that you talked about, how you started off, in the hospital, seeing a wide array of patients, different conditions, and then you went on to do your private practice. You still were involved. For some early clinicians, because this day, and I'm talking like I'm that old, I'm not that old, but I think many clinicians are like, I want to do sports. I want to do sports. I want to work with a high level athlete. But your whole experience was a little different because you didn't go directly, however, but you did have those opportunities that opened up. What could you kind of advise young clinicians to do just regarding to gaining the experience, but also not being in such a rush to work for a professional team or work for a college team?
Oh, Tara, I could not emphasize more exactly what you're saying, that it's fine to have this ambition to want to work with the highest level athletes, but the need is actually at the community level, and you gain so much confidence and experience by working at the community level and so much reward. So my first job was working with local football clubs, and it gave me the confidence to be able to deal with really, nasty injuries that occur on the field in those games. So head injuries and spinal injuries and mouth injuries. Yeah. And through that, you understand how to communicate with coaches and how to direct players. You have the scope to develop injury prevention practices and your skills with things like taping and really on-field injury management, that in a really safe environment that is, there is much sort of lower levels of consequences and more supportive environment than in that elite sporting environment. So by the time Australia got the Olympics, I was working in private practice and working at the velodrome, like I was telling you. And at that time, I think it was 6, maybe 7 years before the Sydney Olympics, I basically made a pact with myself that I would work at the Olympics somehow.
Yeah.
And, as it turned out, I did end up going with the National Women's Water Polo team. But, there's lots of different ways to work with sport. You don't have to go straight into the high-paying professional job. Yeah. Just volunteering at the local community club is a really nice place to start. And then if you're good and you work well with teams, because sometimes it's the soft skills that are the more important skills than your actual physiotherapy skills, and your ability to work with the team and communicate with athletes and coaches, that ensures your ongoing success in the sporting environment.
I agree with you. Yeah. For me right now, I actually work in a clinic, but I see athletes. But I love the setting because it allows me the freedom to also be a journalist, which I love too. So I agree with you. I think you can get creative with how you still work with athletes if that's really what you want to do. Now, we do have to go back to the Olympics. So you worked, and correct me if I'm wrong, 3 Olympics?
Correct, yes. So my first Olympics, I went with the National Women's Water Polo team. And that was Sydney Olympics, and I was working allocated to the team. And then I had a baby in 2003, but I was nominated because I was still working with the women's water polo team. So I was nominated by that sporting organisation for headquarters. But because I was pregnant and having babies, I didn't travel with the team so much. So I then worked in headquarters for Athens and also for Beijing. But by the time Beijing came, I was working with water polo more than what I was prior to Athens, because I was doing their sports medicine coordination role, which meant that I was basically allocating their providers that would travel, and I was training them. I was running the annual conference and working out all of the service provision across all professions for the sport.
And for the Beijing, were you on site, I imagine, for that one, or were you able to do that?
Yeah, so both of them, so both Athens and Beijing, I was in the headquarters, which meant that we provided services to the smaller sports that didn't have enough athletes to justify a full team physiotherapist. Yeah. So the sports that I worked with in Athens was men's gymnastics, archery and fencing. And then for Beijing, I worked with the beach volleyball and fencing as well, and then helped with some of the other sports that I had a connection with.
And how long was that? I mean, obviously Olympics, athletes are preparing for nearly all their life, but for you, given your role, like how early did you start having to prepare? Was this like 2 years, 3 years in advance to get all of that organized?
Yeah, so for Sydney Olympics, I started traveling with the national team in 1996. So women's water polo was not in the Olympics for Atlanta, but we had an Olympic tournament in Holland. So I went with them to the Olympic tournament, and then I was their sole physio from 96 through to 2000. So it was really, 4 solid years of working with the athletes and the coaches, and it was amazingly rewarding experience. I loved it.
What did you find most fulfilling in that moment?
Yeah, look, there was a lot of things, and I just actually had an email from one of them just before this interview. So it's the ongoing relationships with these amazing women that is, just brings back fabulous memories for me, really. But watching them evolve from sort of a semi-professional training period in 96 and 97 through to really high-level professional athletes, where they gave up their jobs and moved, centralised in the Sunshine Coast. So some of them moved away from their partners, as did I when I was servicing them as well. So they really gave everything towards the goal of winning the gold medal in the Sydney Olympics. And so to watch that evolution and the commitment that these athletes made was really a fabulous journey to be part of. And then, of course, I don't know if you know, but we won in spectacular style with 10 seconds to go, and we beat the USA.
That's too bad. I wasn't watching then, but thanks I'm sure our US listeners, many of them are aware of that. You Australians are coming along even in soccer. You have Sam Kerr. She's a phenomenal player, but you guys have some other players. I think you actually lost though, right? To the US women's soccer this past Olympics. Do you remember that one?
Yeah, in the quarters.
No, that was a tough one.
It was tough.
See, we got you back. Don't worry.
Yeah. Well, we haven't really beaten the US in women's football.
Yeah, that's true. But sometimes you get close.
Not many countries have those. So.
Yeah, I agree with you. Not many, but they're all coming along. Well, Andrea, I know we have to get into some of the hip, but before we do that, I'm curious, what is your week like? Because you're a research fellow, are you still practicing as well in the clinic? What's going on there?
Yeah, so at the moment, I'm in my final year of a 0.8 funded, sort of government funded research fellowship, which is through our National Health and Medical Research Council. So these are highly competitive fellowship grants that I was lucky enough to obtain. basically the year I submitted my PhD. So I've been pretty lucky with that. So yeah, that's a 0.8 funded research position. And I'm also I do 1 day in the clinic, which is a very long day. So I do that on a Tuesday, and I do my research work Monday, Wednesday, Thursday, Friday, and then Saturday I catch up with my patient stuff. And I also started doing a bit of subject coordination for the sports masters as well. So doing a little bit of teaching now as well, and editorial work for BJSM and JSAMS.
Yeah, I see that. You're like all over.
It's a very busy, it's a little bit too busy schedule, but anyway.
So those patients you see on Tuesday, are they like patients you're seeing from another clinician, or are they actually your patients? Because I can imagine all of those patients, you only need to see them once a week.
No, that's not the case.
Yeah.
But look, sometimes I do. So sometimes it's a tertiary referral. So I've had patients sent to me from other parts of Australia, and they just come in for an opinion, and then they go back to their physios, or they go back to the treating physician of some sort. But mostly they're ongoing patients that have specifically sent to me as a specialist sports physio. So they're often people that have attended other clinics and haven't been successful, or want to avoid surgery. Or the other part of my patient population, which of course I love, is the adolescent male football player. Through because both my sons are football players, and my youngest son is competitive. So he has quite a lot of colleagues, should I say, who parents like to bring their kids to see me. So they're delightful, and I've been managing some pretty tricky injuries with them, and that's been good.
What's been the most trickiest adolescent hip injury?
The hip injuries have been fine. Like they're it's more I've actually had 3 adolescent lumbar stress fractures in the football players, and it's correlated with the big alterations in training load that occurred due to the lockdowns and change in schedule and growth. So the combination of the two has been the main factors for like being in a growth spurt, and also having this altered training load due to the pandemic has I think been the main source for those players. Because working at the AIS, we worked Australian Institute of Sport. We had junior football players there the whole time I was there, similar ages, so 16, 17, maybe slightly past their growth spurt for some of them, but we very rarely saw lumbar stress fractures. So
I was like, I don't even know that I've actually ever seen one here.
Yeah, to have had 3 in the last 2 years is quite unusual.
You said your kids are competitive. How old are they? Are they?
So I have one who's 18, just started university. So he was the one that was born just before the Athens Olympics.
Okay.
And I have another boy who's just turned 15. So he's on the cusp of deciding whether he's going to make it in professional football or not.
Okay. Well, cool. Well, Andrea, I have to say this because you became a PT before I was born. Not to make you sound old, but you were 1988. And since then, you've got all this knowledge. You went on to get your PhD in hip and groin, in football players. And you worked out in Aspetar Sports Medicine Hospital. How did you migrate there? Had you decided you want to do your PhD and then you went there? How did that happen? Yeah,
that's a great question. So I had the best job in the world for a long time. So I started at the Australian Institute of Sport in 1995. And for someone like me who always dreamed of working with Olympic sports, Olympics was always something that was I marveled at. It was really the dream job, and then obviously to go to those Olympics. But by the time, sort of between Beijing and London, there was a big fallout in terms of funding from the Sydney Olympics, and it was becoming more and more difficult to do the same job that we were doing before. There was less just less money around, and just the whole systems were changing. And I think I got to the point where I'd been in the same job for a long time, and I just felt like I needed a change, and to reinvigorate my love of the profession. And I'd been collecting injury epidemiology data for quite a while with the women's water polo team, but I was collecting it more as a service provision rather than for research purposes. And so I felt like
that's just all on your own, pretty much, right?
Yeah. I was just doing because I knew we had to. And I was presenting data and things like that. It was, in the early days of sports injury surveillance. So this is, we're talking the early 2000s. So, it was unusual for someone to be collecting injury data in Olympic sports at that stage. But I soon realised that we weren't collecting in a way that was enough in enough controlled manner to be able to publish the data. So it was helpful for us in terms of clinical purposes, but not really for research purposes. So I realised I needed to learn more about research, and so I was getting to that point sort of towards the end of end of 2011. Where I just thought, I think it's time for a new challenge. My children are heading into school and it's time to focus a bit more on my work.
Yeah.
And my supervisor, Kay Crosley, who's amazing, and if you get the chance to interview her, you would love it. Ooh. She had gone to Sydney Olympics with me, actually, but then had done her PhD straight afterwards. So she was 10 years ahead already. And she was already supervising students, and her students were amazing. Their presentations were fantastic whenever I saw them at conferences. So I basically said to her, look, I'd like to do a PhD and I'd like you to be my supervisor. And at that time I was doing a lot of presenting and with shoulders, because with water polo, that's the main injury, shoulders and hips. And her PhD is in patellofemoral pain. So she basically said to me, look, I can come up to the hip, but I won't go up to the shoulder. And I said, fine, I'll come down to the hip. And that was pretty much, we decided. So we sort of spent the next 12 months working on a project. And in that time, the opportunity at Aspetar came up. They were desperate for they hadn't been open for that long. They had female athletes and female physios, and because of the separation between the male and the female rehabilitation area, they needed a senior female clinician in the female rehabilitation area. So while I was developing my PhD project, the job at Aspetar, started applying for the job at Aspetar, and just felt like at the time I was able to take leave from my Institute of Sport job. So my plan was to go to Aspetar and then come back, but I loved it when I got over there, and realised that I soon wouldn't come back. So it was just one of those things where we started developing the project, went to Aspetar, and it was literally the perfect place to collect the data for the project that we wanted to do. And the Sports Groin Pain Centre had just sort of been started, and
it was a perfect place because you were able to have access to that given population. What else about that?
Everything was perfect. So the people involved, so the fact that Per Holmick, who, as everyone knows, is the grandfather of hip and groin pain research, was running the Sports Groin Pain Centre. So that was amazing. They already had screening practices set up, and they already had injury surveillance underway. So it had been underway for a few years. It just needed a bit more guidance and stricter guidelines, but it was basically the processes were already underway to conduct that research. So the main difficulty that we had was obtaining ethics and adding the X-ray scanning into the screening and more specific groin screening. So it wasn't that.
Well, if you can recall, before you started or before you moved there, what is one thing about groin or hip injuries that maybe really surprised you, that maybe you had this perception about this type of injury or how you rehab it, but then you get to Aspetar and something blows your mind. Did you have that moment?
Not in terms of the clinical aspect of it, because I think by the time I moved to Aspetar, I'd already had, a long history of clinical experience. I think I'd really developed my methods of managing clinical groin pain and using. I mean, Pear's paper was published in 1999. So by the time I got to Aspetar in 2013, I'd been using exercise-based management for a long time for groin pain. So that, I don't think in terms of clinical management, my understanding of the association between hip-related pain and particularly cam morphology and groin pain obviously evolved massively in the time that I was there through the research that we were doing, because at the time, especially with the women's water polo, we were seeing a lot of hip-related groin pain and some, really classic descriptions or diagnoses of femoroacetabular impingement syndrome, and some of those hips were becoming destroyed at very young ages. So I was already evolving in my thinking about femoroacetabular impingement syndrome, but I think at the time that I went over there, it was like it was this new condition that had just been discovered. And what we were seeing in Australia was a lot of athletes, particularly a lot of football players of various codes, but particularly soccer, but also Australian football, who were presenting with a cam morphology and groin pain. And then because they had cam morphology, they were treated as hip-related groin pain when really they were adductor-related groin pain. So that was the big impetus to do the study that I did. Was I was concerned that was potentially a lot of unnecessary surgery happening and potentially destroying a lot of hips unnecessarily. So that's the big evolution, I think, that happened around that time of commencing my PhD.
Do you think that happens? I feel like that probably happens a lot less now. What do you think?
Yeah, definitely. Well, the research that we have been able to produce has really shown how that it's actually more common to have a cam morphology than not if you play a lot of sport at adolescent. And so now, and I think since the Warwick Agreement, where it's really very clear that that asymptomatic FAI does not exist. It's either a cam morphology, which is a normal variant, or they have femoroacetabular impingement syndrome. Now, we don't want to miss the players with femoroacetabular impingement syndrome, because that's a very debilitating condition. But we also have to be really careful over diagnosing the association or the relationship between cam morphology and groin pain, and ignoring the cam if they don't have femoroacetabular impingement syndrome.
Right. Now, before we actually talk about the hip examination, some rehab considerations, when you were in Aspetar, you stayed there for 4.5 years.
Yeah.
So you finished your PhD and then you left back to Australia? Was that how it went?
Basically, I hadn't quite finished. So I would have loved to have finished and been able to stay at Aspetar, but unfortunately, well, I shouldn't say unfortunately, but my oldest child was heading into year 8, which is second year of high school here in Australia. And we probably kept him in Qatar 1 year longer than what we should have. So he really needed to come home and finish his schooling in Australia. He wasn't thriving so well in Qatar. So, so I was hoping to have sort of finished my thesis before I came home. But as it turned out, I came home and then wrote up my thesis. And then I started my job at LaTrobe. Yeah.
So your whole family moved with you to Qatar?
Yeah.
Oh, that's pretty sweet.
So my youngest son was just turned 6 when we arrived, and my oldest son was 9. It was fantastic for them.
What was the biggest cultural difference for them?
That's a good question. What was the biggest?
I guess I technically have to ask them, right? What about for you?
One of them's here if you want to.
Oh, yeah.
If you want to meet you.
I'm curious.
Do you want me to grab you?
Yeah, go grab them. I'm curious because they're young kids.
Orlando, can you come here for a sec, please? He's now actually studying international relations and security and Middle Eastern politics and Asian politics at university. And we're pretty sure that his experiences in Qatar really shaped what he wants to do.
I can imagine. Very big into culture, I can tell. Well, hello there.
Hello, and Tara's a physiotherapist in the States and works with soccer.
Oh,
and
cool.
she's just interviewing me, so she wanted to ask.
Because she's a star in the sports medicine world. But I was curious because you lived in Qatar, and I was curious, what was the biggest difference for you living there compared to Australia?
That you don't really meet the same person twice. Probably the biggest thing. In
You
Australia,
don't meet the same person twice, so it's that big.
The same person in 100 different circumstances, but in Qatar, every single person is someone different with a completely different life.
Huh. So does that mean you can't make friends easily?
No. You can. Yeah, it's easy to make friends. I found it pretty easy to make friends. We'll just talk to people, but there's just so many different.
So much more variety.
Yeah, variety of people and stories and stuff.
Interesting.
Different cultural background.
Okay.
Yeah.
Well, cool. Thanks. Now, what about you, Andrea? What was the biggest difference for you?
Well, it's very interesting. A lot of people have asked me, as a female, a professional female, did I feel that I was treated with less respect, or, did I experience misogyny? And I always said to people, I felt so much more respected as a professional in Qatar than I ever have in Australia. And
that's awesome.
Working in sport in Australia it's improving, but it was extremely misogynistic. And I have had some pretty negative experiences working in sport in Australia, but over there, I was almost revered. It was actually really, really lovely. I felt very equal with a lot of the other staff there. So for me, that was surprising, and a really positive experience.
Yeah.
And I think, the best, without doubt, the best thing of working there was being able to work together with people from all different backgrounds and different educational experiences and different cultures. And, we were all bonded by trying to navigate the Middle East and living in the Middle East, and with the weather and the different cultural practices, etc. But, it was like being on camp, you become so close in such a short period of time because of that combined experience. So for me, that was definitely the best part of working at Aspetar.
Well, let's jump right into some of the hip stuff, because there are going to be especially clinicians that maybe want to improve their clinical reasoning. This is not a master course, so we're not diving deep into it, but just some general topics that I've just been thinking about. So I listened to probably one podcast, and there was another YouTube you did. But you guys talked about strength testing of the lower extremity, say when we're talking about groin, hip. And there are several ways to measure strength with the dynamometer, but it seems you complete the break test. From your clinical experience, I guess first for our listeners, how does this differ from the make test, and why do you feel that it's important to do it that way when we're talking about returning them to full function, good movement?
Yeah, great question. It is a bit controversial. So in terms of looking at the error levels and reliability, it does look like using make tests is slightly better than break tests, but the break test is still good enough in terms of error of measurement and reliability. But the biggest reason why we use the break test is because it is better able to differentiate between painful and non-painful limbs, and also it's better able to demonstrate deficits when a player has been injured. So when you're going through your rehabilitation, they will restore normal testing compared to the other limb or to pre-injury levels using an isometric or an isotonic test, a make test, but you'll still see up to a 30% deficit in the eccentric test. So it's just better able to differentiate those higher levels of strength following injury, and particularly in elite athletes. So that's why it better correlates with symptoms and better correlates with higher level of performance.
Gotcha. So that eccentric contraction in that break test is definitely a good way that translates more to their actual functional activities like kicking a ball, pretty much.
Yeah, and it just picks up the deficits at those higher levels of strength. Yeah.
Okay.
Yeah.
And then when we think about groin rehabilitation, it's obviously critically important to be assessing the athlete's tolerance to load. You guys, or I want to say, is it Andre? I'm forgetting his name. Andrea, yeah.
Yeah, he was my colleague.
I really should know all of y'all's names because I've read the papers with the groin rehab. But you all like to definitely assess the bent knee fallout. Why that specific test? And then what are some other critical components that you look at? And given every athlete is different, so I'm not going to imagine you to name off everything, but what are like some really key things that you always try to look at when we're just rehabbing a groin injury?
Yeah, so the most important pain provocation test, which seems to correlate best with symptoms, and particularly with the patient-reported outcome measure of the Hagos, is the long adduction squeeze, or the 5-second Copenhagen adduction squeeze. So pain on that test seems to be very sensitive, picking up early signs of groin pain, early signs of overload. So when an athlete is returning to play, that's a really nice sensitive test to use in terms of measuring their response to load and being able to very gradually or very safely progress their load when returning to play. So that's the number one, is that 5-second long adduction squeeze. The bent knee fallout is really good for looking at adductor tone. So, and Andreas has done a study actually in surgery when he was able to find that it correlated nicely with the length of the adductor muscle. So we use that test really because a lot of athletes will develop a bit of increased tone in their muscles prior to developing pain due to adductor-related groin pain or in conjunction with pain. So the bent knee fallout's really, again, a sensitive test. It has good accuracy, so you can easily use it to look at perhaps changes in tone, which may be a precursor to them developing pain in that return to play process. Yeah.
So would you say, like, say if a sports PT is working with a club, a soccer team, let's say that, say they're just doing kind of a general screening for all the athletes. So you would say this is certainly a test or screen that you would put in the toolbox and just run through with every athlete just to assess their tone, even if they don't have any pain or tightness complaints?
So the bent knee fallout, I probably wouldn't. There's not enough information to show that it's beneficial in asymptomatic athletes.
Yeah.
But it's useful in symptomatic athletes. The 5-second squeeze is really, really helpful for picking up early signs of groin pain. So that's probably the one test that I would run with them regularly, like once a week, say. Just get them all to do their 5-second squeeze, and those that have symptoms on that test, maybe you want to investigate a little bit more. If they don't have any symptoms on that test, they're good to go.
Okay. And then when we talk about the 5-second squeeze, you talked about how we should be kind of assessing the athlete's tolerance after exercising. Now, do you have the athlete perform the 5-second squeeze? Say we do a strenuous, I don't know, functional sprint and changing directions, and then you have them do the squeeze test, or do you actually have them do it at the very end of their training session? Because I imagine that you also want to be on top of it before they go and pull another groin injury. When do you actually have them?
So one thing I've learned about working with athletes is that they're obsessed with their bodies. So I certainly wouldn't be doing the test every day.
Yeah.
Maximum once a week, and doing it at a consistent time of the day and consistent day of the week. So maybe on a Monday morning after they've recovered from their weekend games, you just put everyone through the 5-second squeeze, and that's it, you're done for the week. I wouldn't be reassessing it through the week unless they're an injured athlete returning to play. So an asymptomatic athlete, it's just a very quick screen to identify those that may be at risk of groin pain. So like a secondary prevention measure. Yeah, so early signs of groin pain. Yeah.
What about the symptomatic athletes?
So with the symptomatic athletes, I would test them. If you're seeing them, if you're progressing them every day, you might want to test it every day to see how they've recovered from the day before. But I wouldn't do an exercise, then test it, do an exercise, then test it, because it doesn't, it's fluid, it changes, the response changes. So you might be, if you've say set them a rehabilitation session, and then the next time you see them, you want to determine, well, how should I progress that session? That's the time that you might do it as an assessment tool.
Gotcha. Okay. And running speed, we know kind of that can help guide us, or at least indicate that someone could possibly have something coming. When you're trying to progress an athlete to full running speed, I'm curious what needs to happen before they're even sprinting for you? Like, what are the goals that they need to meet before they full out sprint, let's say 90 to 100%?
Yeah, so they need to have, it's really about developing their resistance to load. So they need to have been able to jog and run at 50% pace, and then I develop it up to 75% pace, and then up to 80% pace. And with those kind of, it does depend on the injury, but the average, say, long-standing groin pain, you might keep the same session for say 2 or 3 sessions, monitor their response to load, and if they cope with that, then progress for another 2 or 3 sessions and progress. So I will never allow an athlete to sprint 100% unless they have gradually built up their speed and their ability to tolerate repeat sprints at 50%, 75%, 85%, 90%, and then eventually they can go all out. So that period, it depends on the athlete, depends on the injury, but that period, that may take 4 weeks.
Yeah.
Time of just starting to jog to the time of being able to sprint.
Right. And I like how you made it a point where it's not just one session, like we're checking this out a couple times for sure. And then when we think about athletes full out sprinting, because I think every clinician does their own thing, but sometimes it seems that, we don't actually go through like the single leg functional activities such as star excursion or different things in the rehab. How early do you think that should be implemented before we're even talking about running?
Yeah, that's a great point. So in fact, when it comes to groin pain, often straight line running and even sprinting is actually less provocative than some of the change in direction activities. So they could be sprinting in a straight line and still not kicking a ball. So it's that because of the nature of the adductor related groin pain. So those things progress at different levels. So you might have them starting to jog in a straight, around an oval or in a straight line, and at the same time just starting very gentle slide board work. So they're practicing that change of direction type stuff, and they might comfortably be able to run at a decent pace before you start doing some zigzag work or some change in direction type tasks on the field and some kicking. So the progression of single leg work, and if you look at Per Holmick's original program, which still stands, very strong today, there is a lot of single leg stance work in that program. So single leg slide board work and the cross country skiing, etc. So doing you have to have single leg stuff to be able to prop and change direction and to kick. So having single leg functional work as a component of your program as soon as symptoms allow is really important.
Yeah. And from your personal experience, because you mentioned that sometimes you'll have athletes come there just to get a third opinion, fourth opinion, who knows how many opinions. Where do you think clinicians may not go wrong, but maybe things that maybe they might miss, or maybe things that you think are not necessary that for an athlete to fully recover?
Yeah, I think one of the main things I would say, particularly amongst the Australian physios, because that's my main clinical experience, it's just not progressing load high enough during the rehabilitation process, such that when they return to sport, they're experiencing loads that they're actually haven't prepared their body for and training. So that's I think the thing that I can provide mainly through the clinical experience I've had working with elite athletes for all those years, is making sure the stimulus in their rehabilitation program and through the retraining process is as close to replicating what they need to go back to sport. And that's not just at a local neuromuscular level, but also in terms of cardiovascular fitness, in terms of looking at some of the other risk factors for injuries. So, making sure they do their Nordic hamstring exercise, making sure they're doing their proprioception so they don't go out and get an ankle injury. So it's all the other factors that we need to treat the athlete really holistically when it comes to rehabilitating them back to sport following a major injury like that.
Yeah, that was good. And when you were talking about load and all this stuff, I was thinking you're Tim Gabbett for a second, because I went to his course, and you also have done papers with him too. I've had him as a guest. But yeah, during his conference, he mentioned, which yes, we all know, but we kind of don't know because not everyone does it. But the fact that sometimes the rehabilitation, there's just this big gap between to when they actually need to play on the field. They haven't been trained for the most stressful part of their actual sport. So, and that's definitely something I think, even as a clinician, I don't know that PT schools, at least in the States, they go through that. That's like training that you have to seek after physical therapy school. Would you say that's how it is in Australia too?
Definitely. And look, some of the physios that have either come from being elite athletes themselves, or have done maybe done exercise physiology before they've done physiotherapy, do really well in that aspect, because they just have better training when it comes to the sport specific type training. But my most rewarding and most successful partnerships have been with when I've worked together with usually assistant coaches, but sometimes head coaches, who take on the injured athlete as a project, and together we work out a return to play training program, which incorporates all of the sport specific skills that they need, as well as the training stimulus. And I can advise in terms of the injury, and then they come at it from the sport specific side. So that's when it's always worked the best.
Yeah. And those assistant coaches too, you provide your expertise, but I imagine though you also are talking about, hey, the Copenhagen or the FIFA 11, these are programs that you can do throughout the season. For early clinicians, how can they communicate how important that is? Because we all know that FIFA 11 plus, even not just for ACL injuries, for other injuries, that it can serve as a protective, or not protective, but help to reduce the number of injuries. But I also feel like if teams don't really understand that, if that doesn't come across as being that important, it's not going to be important for any player. How do you communicate that with your teams and your coaches?
Yeah, the best sell is to really point to the evidence of such a strong relationship between athlete availability and success in team sporting success. So showing that the teams that do the best are the ones that have the least number of injuries, and there's very clear evidence of that now. And always bring up, some of the UEFA teams that have won Champions League and have had the lowest level of injuries or highest level of athlete availability. So that's really linking it to performance is the most successful tactic I've found over the years in terms of including injury prevention, and being really judicious about what your recommendations are. So if you go in all guns blazing and saying, you need to replace your warm up with this 20 minutes of stuff that I'm going to prescribe to you, they're not going to accept that. But if you come in and saying, perhaps we can adjust the warm up to add these couple of extra things, and it's going to make a really big difference in terms of the number of hamstring strains or groin injuries, the main injuries that keeps players out off the field, then I've always had success with that. But it's about building that relationship and trust between yourself and the coach is essential, and working as a partnership and for the benefit of the team. If you really show that you're doing it because you want the team to be successful, then that's always been a good tactic, I found.
Yeah. So you never really had issues then, huh? Or did you?
Oh, I wouldn't say that. It was very difficult with gymnastics. Gymnastics was probably the most difficult culture to overcome. But
why is that? I'm curious.
It's a very rigid culture. I mean, all of this stuff that's coming out with gymnastics all over the world now in terms of how the lack of autonomy of athletes and some of the potential borderline abuse sort of relationships that occur between coaches and athletes. So we're not even talking about Larry Nassar, but just the culture of the sport in general. And the fact that we're often dealing with underage athletes and therefore massive power relationships. So it's a unique culture, I think, the performance arts sports. Water polo, I was lucky because all the coaches I worked with had been my patients when I first started at the Institute of Sport, and they went on to become coaches. So I already had really strong established relationships with the coaches. So, and that's the key. You really must invest in those relationships, not just with the coach, but with the doctors and other members of the multidisciplinary team. Without investing in those relationships, your job, it's just much harder to be successful in your job, I think.
Now, Andrea, realistically though, you were in the clinic working. How do you still invest in relationships when you also have a busy schedule? Is it like you might shoot them a message and say, hey, or because I can't imagine you going to meet an assistant coach every other day to just get to know them. What did it look like for you?
So what I've always found helpful, and I think it really started way back when I described this swimming coach, is going to their environment and being in the training environment. It's absolutely essential that you stand with the coach, with the support team, and just watch the relationship between them and the players, watch how the players move, and spend the time to be in the sporting environment. It's really difficult to establish those relationships if you're only ever in the clinic. So yes, it is time consuming, but
that's what you got to do then.
Yeah. You've got to do it. And sometimes it requires a lot of volunteerism. So a lot of time spent that you're not necessarily going to get paid for, but that's if you want to be successful in your job, that's kind of what you need to do. And when I was at the Institute of Sport, we the athletes all trained on site, so that was a lot easier when I was there. But I love watching sports, so it was never a chore for me to go and watch the training environment. I found it really fascinating, and I learned a lot about the athletes, about their relationship with the coaches, and sometimes some of those biopsychosocial factors that you may not have been aware of become much more apparent in the athletes that you're managing for injuries when you can see the dynamics that are occurring on the training environment. So it can actually really assist you in your management as well.
Cool. Well, before I ask you for advice for future therapists who hope to be more involved with sports, last question regarding to screening. As we know, screening is not as effective in determining those that will have a groin injury. But just what would you recommend a therapist, or how would you recommend a therapist educate an athlete regarding to when they should recover? Because it does look like groin injuries can be straightforward. Oh, you have a mild strain, but we find some of these athletes are still not back within a month. They're still out for nearly 3 months. What would you communicate with an athlete early on so they are not surprised if they are a little behind more than 2 weeks, or maybe they're at 3 months and they're still not recovered? What would you communicate when it comes to the actual rehab and getting back to full performance?
Yeah, so the athletes that have sustained an acute injury, we do have some evidence of that their return to play time can be predicted a little better by some of the clinical examination, and that's based on Andreas's work. So, but the important thing I think to stress to athletes on that initial consult is that groin pain can be resistant to rehabilitation, and it has a very high level of recurrence, and it is the second or third most common injury experienced by football players. So I don't mean to scare athletes into doing what they're told, but I guess in a way it's a little bit at that really early phase. I make that very clear that groin pain can be one of those injuries that can be very difficult to recover from and can result in long-term problems, which can really interfere with your performance, and has one of the highest levels of recurrence of all musculoskeletal injuries seen in football players or in any kind of athletes. So I use that information and that education process really to get buy-in to the rehabilitation. And I think it's really important not to give timeframes, but to actually give milestones and goals. So we say when this particular test is less than 4 out of 10, then we can start you on this, and then so give them an idea of how you will progress rather than timeframes. And I think that then they can see the path, and it's not necessarily dictated by timeframes.
By time, which really shouldn't be dictated by time. Really should be a criterion thing.
Criterion-based rehab.
Grace, I like that. Good. Okay, now, if you were a young clinician, what advice do you wish you heard when working with athletes?
Don't be a fan.
Were you a fan at one point?
I think I probably, when I was a young physio, I wouldn't say fan, but I guess this is what I see in other young clinicians. So for me, be confident in your diagnosis, be confident in your skills. That is probably trust your judgment. I think that's probably the thing that the advice that I would have liked someone to have told me when I first started working as a physio, because I think I often sort of mistrusted my own judgment and findings, and it wasn't until I had more experience that I then felt much more confident and trust my initial judgments. So that's probably the best advice to give young physios. Is really thorough, be very thorough in your questioning, really deeply listen to what the athlete's telling you, and develop your clinical reasoning based from what they're telling you, and then trust your judgment when you're confident that you've given a thorough interview and physical assessment.
I like that. Well, Andrea, what's going on next for you? It seems like you're also involved in some research for women in sports, which they deserve. What's going on with that? Is that one of the projects you're working on too now that's keeping you busy?
Yeah, so we're doing a implementation project looking at a prevention program for community women's football. So that's really exciting. We're also looking at some of the barriers of facilitators for women working in sport. So yeah, we're really interested in that, and we're going to run a conference in the middle of the year looking at women athletes and women working in sport and leadership and some of the barriers, and try to develop a network to encourage more women to work in sport and make the path a little less stressful than probably what I had to experience through my early days. Still continuing to work with the Force project. So we're now up to 5 years of data collection for our prospective cohort of athletes with hip and groin pain. Just dabbling a little bit in concussion as well.
Oh, and concussion too. Wow. Well, Andrea, I know I took more time than I had, but I am so grateful for your time. Thank you for all of your contributions, let's say that, and your team with all of the people that have been a part of all your research. I know many of us in the States appreciate it, and we use it, especially the Doha agreement, all of the hip related stuff. And obviously you're doing a lot more than just hips, but thank you so much for your time. And hopefully I'll see you in San Diego, because I actually might take a look at that now that I know that's one of the bigger.
Great to meet in person.
Yeah, awesome. And
thanks for tuning in to Medical Experts with Andrea Mosler. Don't forget to download, rate, and subscribe. And